Okay, welcome everybody to today's live webinar. The presentation today is titled Echocardiographic Approaches to Investigate Heart Failure in HIV-1 Infected Humanized Mice. So before we begin the presentation, I have a couple of notes about this webinar. The webinar will be recorded and it will be made available to you afterwards. All the lines will be muted throughout the duration of the webinar. If you do have a question, please use the Q&A button located at the bottom of the screen throughout the presentation. Those questions will then be answered at the end of the session. And we expect the webinar to go about 30-35 minutes, and we will include about 5 minutes to answer those questions. Our presenter today is Dr. Bryan Hackfort. He earned his PhD in 2014 from Creighton University in biomedical sciences. His research interests over the years have focused on osteoporosis, cardiovascular disease, and circulatory physiology. He's currently an instructor at the University of Nebraska Medical Center and the Department of Cellular and Integrative Physiology. Other academic appointments include the Director of Small Animal Ultrasound Core at the University of Nebraska Medical Center and Adjunct Professor at Metropolitan Community College in Omaha, Nebraska. So thank you very much, Bryan, for agreeing to share your research today. And with that, I will let you get going.
All right, thank you for giving me this opportunity to share some of the research that we have going on here at UNMC. As you mentioned, we're going to talk about some of our echocardiographic approaches to this humanized HIV model that we were developed here at UNMC. So I'm the director of the Small Animal Ultrasound Core. I did the ultrasound imaging and played a role with kind of developing some of the different ideas for types of using the ultrasound to investigate the questions we wanted to answer. Dr. Kishore Bidasi is the main kind of driver for this research. It's kind of his ideas and pushing forward, and does a lot of the analysis for photoacoustics. Doctors Dash and Grantla play a role in developing the humanized HIV-1 mouse. And did the work on the flow cytometry, animal work, as well as the histology after the animals were sacrificed. So today, I'd just like to introduce cardiac dysfunction HIV-1 and why it's really important that we have a model that we can investigate the pathways that HIV-1 affects cardiac function. So to do this, I'll go into the generation of HIV-1 infected humanized mouse model. We'll look at diastolic and systolic dysfunction in these mice and how it compares or how it relates to the human cardiac dysfunction. And then we did a study where we treated the HIV-1 infected mice with an adeno-associated virus that overexpressed galactolase-1 via an endothelium promoter, and see how that altered the cardiac dysfunction. And then finally, we just started working on a project where we looked at treatment with an antiretroviral cocktail and looked at some photoacoustic EKV imaging. So people with HIV are living longer, and thanks to antiretroviral therapies. However, they are at a higher risk for cardiovascular disease. So the red bars here are HIV positive, and the blue bars are HIV negative people. And it shows that HIV positive have a higher risk for cardiovascular disease starting at a much younger age. 40% of the people with HIV-1 on long-term antiretroviral therapies develop heart failure. And so there's other models to investigate HIV-1. There's the SIV model. However, that's expensive. and relates well, but it's expensive and hard to do. And so we need a mouse model to investigate potential mechanisms of heart failure in HIV-1 animals. And so there's been lots of publications that show that there's diastolic dysfunctions with humans with HIV, as well as other cardiac dysfunctions in humans with HIV. So Dr. Grantla played a role in developing this humanized mouse model, where they took newborn nod-skid mice, they irradiated them, and then repopularized with human CD34 hematopoietic stem cells into the liver of these newborn mice. The CD34 cells colonize the bone marrow and thymus. Over time, this led to maturation of the human leukocytes that then colonize the brain, lymphoid tissue, and the gut. And blood samples and flow cytometry were done to confirm the humanized leukocytes in these animals. However, Dr. Biddisy wanted to know if these animals showed a similar cardiac phenotype as the human HIV model. So they have the humanized leukocytes, but does this progress to a similar cardiac dysfunction seen in humans? And so for the rest of this talk, we're going to talk about or look at the cardiac phenotype. So humanization of these mice occurred at birth, and then we waited 18 weeks for the human leukocytes to develop and mature in these mice. Echo analysis was then done every 4 weeks for 16 weeks. At time 0, after the first initial ultrasound, mice were infected with HIV and allowed to progress for 16 weeks. As we look, the body weight was not significantly different between the humanized mice that were uninfected and the humanized mice that were infected with HIV. We see that starting at 4 weeks post HIV infection, there's about 1.2 to 1.5 times 10 to the 5 RNA copies of HIV-1 per milliliter of blood. And we see that there's a slow but steady decline in the CD4 positive population of T cells in the blood of the infected mice. Whereas in the humanized mice, we don't see a change at all in the CD4 population. So this kind of shows that the HIV-infected mice have HIV-1 viral load in their plasma, and it's targeting these CD4 positive T cells. So this slide is more of a just kind of an introduction to different types of heart failure models that we're going to investigate with these mice. So many people think of heart failure, they think of the heart failure reserved ejection fraction, which is due to systolic dysfunction. If we look on the upper middle, we see this is a typical M mode on a long axis image, where we then measure the kind of the wall, where we get a diameter and we can calculate a volume. A typical ejection fraction on mice is mid-60s to mid-70%. And systolic dysfunction can be below 40% ejection fraction. As seen here, where the walls lose their contractility, they're not contracting down as far as the normal mouse. This paper focuses a lot on diastolic dysfunction, which is more of the heart failure with preserved ejection fraction. Oftentimes with the diastolic dysfunction, it can happen before we see changes in systolic function, and is due to a lack of contractile properties or relaxation properties of the heart. In a normal animal, To measure diastolic dysfunction, we use an apical 4-chamber view where we take the transducer, we point through the apex of the heart up towards the mitral valve. And in a normal animal, we'll see this nice E peak and A peak. So the E is the kind of passive filling, the relaxation of the ventricle, and the A is the atrial component when the atria contracts to fill the heart. In a normal animal, this ratio of the E to A peak is about 1.5, as seen in the normal images here. So that's the E peak here and the A peak, and then the ratio calculated is about 1.5. As we progress through heart failure, different changes in atrial pressure or fibrosis of the ventricle can change the ratio of the peak from less than 1 to a more severe where it's greater than 2. The ratio of the E to A is greater than 2. In the example here where we have grade 3 mitral flow dysfunction, we can see that the E peak is a lot larger than the A peak, and so this ratio leads to about 2.5 in this example. We can also use the mitral flow pattern in order to calculate parameters such as mitral velocity deceleration time, the isovolumic relaxation time, isovolumic contraction time, and aortic ejection time. And together, all of them tell different parts of the relaxation of the ventricle and can lead to build a bigger picture of what's going on with the diastolic dysfunction. And then finally on the right is an example of a normal tissue Doppler, where instead of measuring the blood flow into the heart, we put the gate on the ventricle wall next to the mitral annulus. And so here we're actually measuring the muscle movement instead of the blood flow into the heart. When we look at the diastolic dysfunction in our humanized mice, we don't see a change in the uninfected humanized mice. And I know there's a lot going on here. I'll zoom in a second, but I just wanted to point out that there's really no change in the diastolic dysfunction in the humanized mice. Okay. However, at 4 weeks post-HIV-1 infection, we see diastolic changes start to occur with the peaks in the HIV-1 infected mice. At 8 weeks, we see small changes in systolic parameters, including the ejection fraction, fractional shortening, and the end systolic diameter. And the diastolic dysfunction continues to progress. In the example I pulled up, the top, excuse me, is the uninfected humanized mice at week 0 and week 16. There's no diastolic dysfunction in the mitral flow or the tissue Doppler parameters. However, the HIV-1 infected mice, you can see that the mitral deceleration has been reduced. The E to A ratio is greater than 2, and there's strong diastolic dysfunction. Looking at the data results in graph form, this diastolic dysfunction is primarily due to a decrease in the A wave peak. So it can be due to impaired relaxation of the heart, as well as impaired filling of the ventricle. The E to A ratio, starting at 4 weeks post-HIV infection, is greater than 2 and can range between 2.2 to 3. The mitral velocity deceleration time, which is another measure of impaired relaxation, is decreased starting at 8 weeks post-HIV infection. Isovolumic relaxation time and the isovolumic contraction time, again, both measures of impaired relaxation and diastolic dysfunction, are increased starting at 8 weeks post HIV infection. So we see a strong diastolic dysfunction that continues to progress as the HIV-1 model progresses. When looking at the systolic function of our HIV-1 animals, the ejection fraction is significantly reduced starting at 8 weeks post-HIV-1 infection. The ejection fraction, or the reduction in the ejection fraction, though it's significant, does not reach levels that are seen in more of the systolic models, such as a myocardial infarction model or a chronic TAC model, where we get ejection fractions down in the 20 to 30%. This systolic function also shows that there's fractional shortening, a reduction in the fractional shortening, as well as an increase in the end systolic volume and diameter. The M-mode images show that the humanized mice maintain their contractility, whereas the HIV-1 infected humanized mice lose that nice contractility as HIV-1 disease progresses through. So in order to kind of zoom in and look at where this dysfunction is occurring, we also have the ability to use cardiac strain analysis. And cardiac strain analysis is just a software package that Visual Sonics has, where we can use speckle tracking to look at how the wall changes throughout the cardiac cycle. In the longitudinal or on the long axis image, we can measure radial strain, which is seen on the top, and longitudinal strain, which is seen on the bottom. Okay, and strain is just a measure of deformation, or how that wall is moving. There's 3 directions or 3 ways that we can measure strain in a heart. Longitudinal is that change in the longitudinal or the long axis. Radial is the shortening of the heart. And then circumferential is more of the kind of twist, how far those pixels are moving when the heart contracts. Okay, so longitudinal strain is measured in the long axis. Radial strain can be measured in the long and the short axis, and circumferential strain can be measured in the short axis. We can also break that B-mode image up into regions, and we can measure the regional strain throughout that heart wall. And so with these peaks, we're measuring the time to peak in the radial and the longitudinal directions. And so this can show how the heart, the dysynchrony in the heart, if each region is contracting and moving at the same time and working together. So when we look at cardiac strain in the HIV-1 model, we see that there's a decreased global circumferential strain, so a decrease in how the twist of the heart as it contracts, as well as a decreased global longitudinal strain. This change in strain occurs at 8 weeks post-HIV-1 infection. I know there's a lot going on down here, but in the uninfected mice, you can see that there's more, or the changes are more uniform. Whereas when we look at the infected mice, we see a lot more dysynchrony. There's a lot more color change throughout, showing that the different parts of the wall aren't working together. There's a lot more dysynchrony with each cardiac cycle. In this first study, We looked at the microvessel perfusion. So just before sacrifice, we injected mice with 40 milligrams per kilogram of bovine serum albumin with fluorescent isothiocyanate, or BSA FIT-C. We waited 10 minutes and then sacrificed the mice. And what this allows us to measure is microvessel leakage, or how leaky the vascular are. We looked in the apex of the myocardium as well as the base of the myocardium, and we see that the vasculature is a lot leakier in HIV-1 animals. We also measured the number of microvessels that were found in these areas, and we saw a significant decrease in the microvessel per unit area in HIV-1. So there's fewer vessels, and the vessels that are there are more leaky. So this suggests that there may be chronic inflammation in the HIV-1 myocardium. We also measured the cardiac fibrosis using the Masson Trichrome Stain, and we saw that there was a significant increase in interstitial and perivascular fibrosis. So the blue is going to be collagen deposition, and we can see that there's significant amount increase in the HIV animals. Collagen can lead to the fibrosis in the heart, which can make the heart stiffer and can impair that relaxation, which may be leading to that diastolic dysfunction that we measured. All right, so my first part, we saw that the HIV-1 infected humanized mice develop cardiac dysfunction over time, which is similar to the human HIV-1 infection. Initially, this is due to an impairment in the ventricle filling and the diastolic dysfunction, but the chronic impairment leads to a decrease in systolic dysfunction. And then at 16 weeks post-HIV infection, mice had the increased microvessel leakage and infiltration of leukocytes and myocardial fibrosis. So our next step was to investigate a mechanism or different mechanisms on why this is occurring. Now that we've shown that we can develop a model that mimics the cardiovascular phenotype in humans, we can then focus on pathways and potential treatments for HIV-1 infection and cardiac dysfunction. Methylglyoxal is a cytotoxic byproduct of glycolysis. When the heart undergoes the ischemia due to the lack of vessels, it then has to change its mechanism for getting energy, and so it undergoes glycolysis. Normally, methylglyoxal is immediately removed and kept at very low levels. Methylglyoxal activates inflammation through the NF-kappa B pathway. It can lead to a production of reactive oxygen species and increases microvascular leakage and fibrosis. Methylglyoxal is increased fourfold in cardiac tissue of HIV-1 patients. And so we thought that this may be an important mechanism that leads to the phenotype we saw in the HIV-1 hearts. So in this study, we again developed the humanized mouse model. We waited 20 weeks for the humanized leukocytes to mature. At T0, we did an ultrasound, and then we injected 2/3 of the animals with HIV-1. At 4 weeks, we did another ultrasound to confirm the diastolic dysfunction. And then half of the infected animals were treated with an adeno-associated virus containing this glyoxylase 1. Glyoxylase 1 is the rate limiting enzyme that reduces the methylglyoxal, and along with glyoxylase 2, we'll convert it to lactic acid and glutathione. After the injection with the adenovirus, we waited another 12 weeks where we did a times 16 ultrasound and then sacrificed the animals at week 17. Here we hypothesized that the microvascular leakage, fibrosis, ischemia, and HIV-1 induced heart failure may be due to the increased methylglyoxal accumulation. Again, we started by looking at the diastolic dysfunction. The top shows the uninfected mice had no change in any of the diastolic parameters. The middle is the HIV-1 infected mice at 0, 5, or 4 in week 16. And the bottom is the humanized mice that were treated with the adenovirus. So I zoomed in on the humanized mice at week 4 and 16, as well as the treated mice at week 4 and 16. And at week 4, both the HIV mice and the group prior to the treatment of the AAV29 had diastolic dysfunction. So we look at the data, the A wave is significantly decreased, which is the same as what we saw in our initial study where we characterized this HIV model. However, after treatment with the glyoxylase 1, we saw that the diastolic dysfunction was mitigated or removed, and the cardiac function was similar to the uninfected mice. We see that with the traces as well as in the echo results. We saw a similar story with the systolic function, where the HIV-infected mice had reduced systolic function at 16 weeks. However, the treatment with the glyoxylase 1 restored the systolic function at 16 weeks. So these images represent another way we can show the cardiac strain, where we just map the velocity and the change of the pixels. On the left is the uninfected humanized mice, where we see the velocity is large and the deformation or strain is big. The middle, we can see those kind of, the change is smaller. And this is restored at 16 weeks in the glyoxylase 1 treated mice. When looking at the global longitudinal strain, again in HIV-1, it's decreased at 5 and 16 weeks. In the treated animals, it was reduced prior to treatment and partially restored after the glyoxylase 1 treatment. When looking at those representative images of how the myocardium is contracting, we see a nice uniform contraction in the radial and the longitudinal strain. In the normal animals, we see a lot of dyssynchrony in the HIV-1 mice, which is partially restored in those glyoxylase 1 treated animals. So after the animals were sacrificed, we again did the looked for microvascular leakage. We saw that HIV-1 animals had increased leakage, which was partially restored by the treatment of the glyoxylase 1. Interstitial fibrosis and perivascular fibrosis were also partially protected using this glycylase 1 treatment. Over on the left, we measured methylglyoxyl hydroxyimidazole isomer 1 as a surrogate for measuring methylglyoxylate in these animals. We see that the HIV-1 treated animals had about a 4-fold increase in the MGH1, which would be similar to what we see in patients or humans with HIV-1. And at 17 weeks, 12 weeks post AAV treatment, we see that this methylglyoxyl was reduced significantly in the treated group. Looking at glyoxylase 1, the enzyme that we're interested in, we see that it is significantly decreased in HIV-1 animals, and that it's restored in the treated animals. And then finally, we also looked at vascular adhesion protein 1, which is an oxidative enzyme that facilitates the transmigration of inflammatory cells. We see that this enzyme is significantly increased in the HIV-1 animals and is partially mitigated in the treatment with glyoxylase 1. So to conclude, the second study that we did, methylglyoxyl is increased in HIV-1 infected mice. That's similar to what we saw in the human cardiac tissue of HIV-1 patients. Treatment with an adeno-associated virus with glyoxylase 1 behind an endothelin-1 promoter improves the glyoxylase 1 levels in the HIV-1 infected mice. It reduces the methylglyoxyl levels, and it restores the cardiac function measured by echo. We also saw with the histology that there is reduced microvessel leakage and reduced fibrosis in the treated animals. So this would be a potential mechanism that we could move forward and keep investigating as a way to restore cardiac function in the HIV infected animals as well as potentially humans. Our current work and future work is moving to look at the what's going on in the tissue saturation using the PhotoAcoustic EKV. The PhotoAcoustic uses pulsed laser that causes a chromophore to heat and thermoelastically expand. The chromophore then emits a pressure wave that can be detected using the ultrasound transducer. In the case of looking at oxygen saturation, hemoglobin is a natural chromophore, where deoxygenated hemoglobin has a peak at 750 nanometers, and oxygenated hemoglobin has a peak at 850 nanometers. And so when we look at the PhotoAcoustic EKV, looking at oxygen saturation, we alter between pulsing at 750 and 850 nanometers. And then the software can calculate the ratio of the oxygenated and deoxygenated hemoglobin to calculate the tissue saturation. The EKV is ECG-gated kilohertz visualization, where we'll take multiple cardiac cycles and we'll average them based on the ECG trace. This allows us to increase the frame rate from approximately 5 frames per second to hundreds of frames per second, and can allow us to see dynamic changes throughout that cardiac cycle. In our current study, we used the photoacoustics to see if there was a change in the tissue oxygen saturation. On the upper left is the uninfected group. The middle is the infected or HIV-1 infected. And on the right, we used HIV-1 infected plus a antiretroviral therapy. So DTG is an integrase inhibitor, along with reverse transcriptase inhibitors and a nucleoside reverse transcriptase inhibitors. So it's a drug cocktail that is used to reduce the viral load, the HIV-1 viral load in these animals. On the bottom is an example of the photoacoustics looking at oxygen saturation in the tissue. And for this study, we changed the balance of the gas we use while the mice are anesthetized. Typically, we anesthetize mice for ultrasound using 1 to 2% isoflurane, with the balance being 100% oxygen. But that 100% oxygen balance will change the tissue oxygen saturation. So for this study, we used normal room air or 21% oxygen as the balance for the isoflurane, which would be seen here. While we're continuing to measure the oxygen saturation, we switch that balanced gas to 100% oxygen. And we can see that there's an increase in the tissue oxygen saturation level. We waited about 2 minutes, and then we switched back to the 21% oxygen again. And so with this, we saw that in the N stands for normal room air, the H is the hyperoxia, or the 100% oxygen. We can see that there's a significant difference at baseline when they're just breathing the normal air and oxygen saturation between the uninfected animals and the HIV-1 infected animals. While all the animals responded or had a greater oxygen saturation when we switched to the 100% O2, the DTG, or the antiretroviral therapy, did not change the oxygen saturation when compared to just the HIV-1 infected animals. So for this study, we're still doing the analysis for the tissue Doppler, the systolic function, to see if the antiretroviral therapy mitigated the cardiac dysfunction with those parameters. So overall, the humanized mice develop a similar cardiac dysfunction when treated or when infected with HIV-1, as seen in the human HIV-1 patients. Treatment with the adeno-associated virus with glyoxylase 1 restores the cardiac function. It improves vascular leakage. It improves cardiac dysfunction, as well as restores those methylglyoxal levels. And then HIV-1 infection results in lower myocardial oxygen saturation. This may be due to the decreased microvessels that we measured in that initial study, or due to the microvascular leakage with the HIV-1. And so more follow-up studies need to be done to investigate that role of the tissue oxygen saturation. And so with that, I would like to thank Dr. Biddisy. Again, he's the main driver for a lot of this research. Drs. Dash and Grantla play a role in the animal studies, as well as the histology and developing these mouse models. I'd also like to thank the funding from the UNMC Center of Chronic HIV Infection and Aging, as well as the Office of the Vice Chancellor of Research. And then the Ultrasound Corps is supported in part by funding from a Nebraska Center for Nanomedicine COBRA grant. And so with that, I would like to take any questions.
Yeah. All right. Thank you so much, Brian, for that presentation. Definitely a lot of, you can see a lot of effort has went into this, and obviously you got some further research. So hopefully in the future, maybe we can have you back for that. I do have a couple questions coming in here. So if you do have a question, just remember to submit that through the Q&A button at the bottom of your screen here. So the first question that I have is, was any virus getting into the heart? And did you observe any changes in the microbiome driving circulating metabolite changes?
So for these studies, the virus was measured through the just in the bloodstream. So I can't answer if the virus was found in the cardiac tissue itself. And then we did not look at the microbiome for this study.
Okay. I have one other question here. You see increases in diastolic function and L waves in your mitral flow images. Have you measured blood pressure on those HIV animals or looked at changes in the left atrial diameter?
So as of now, we have not, but in our future studies, we're potentially looking at the change in the atrial diameter, changes in potential right ventricle function and size. I didn't describe fully what that L wave was. The L wave we see is potentially from the increased atrial pressure. It's then blood flow from the pulmonary vein back to the heart. So you have that increased pulmonary hypertension, which is forcing the blood into the left ventricle as it's passively filling. And so you get an extra peak in that mitral flow signal.
Okay, thanks. And then one more question for you. You showed the oxygen saturation did not change with the antiretroviral therapy. I think you might have mentioned this, but did you measure any of the photoacoustic EKV in the AAV treated mice?
We have not looked at that, but in the next step, as we look at that AAV and that glyoxylase 1 treatment, we are proposing to continue with the photoacoustics to see if that changes with the oxygen saturation.
Okay.
If I were to make an assumption, we would probably see an increase in tissue oxygen saturation since we saw the reduction in microvessel leakage and reduction in that, or increase in that number of microvessels. So.
Thank you. All right, looks like that's all the questions that we're going to take for now. If you do have any questions that you want to ask, you can feel free to email us, submit those questions, and we can get those answered for you. So thanks again, everybody, for attending. Thank you, Brian, for that great presentation. A lot of good stuff in there. So just want to say, you know, if you go on our website, there's a lot of great resources on our website at visualsonics.com. You can register for our upcoming webinar or even view our past recordings. And of course, you can find us on any of these social media outlets. So with that, again, thank you. Enjoy the upcoming holidays and the new year, and we will see you on the next webinar.